This lecture will talk about the care of patients with hypertension. There are a number of ways that you can get hypertension. There are a number of different etiologies. One is called primary hypertension. It's also called essential hypertension. It's an increased blood pressure from an unknown cause. Since we don't know what the cause is, we can't treat it, and so we treat the blood pressure. Secondary hypertension is an increased blood pressure from another cause, renal disease, an adrenal tumor, some other reason. So in that case, we can treat the underlying cause, and then hopefully the blood pressure will come down. Then there's also something known as isolated systolic hypertension, which is mostly in older adults, and it's due to aging changes. It's due to the stiffening of your arteries, and so you've got a higher resting systemic vascular resistance. And you can treat that with lifestyle modifications, usually before medications are used. Blood pressure is determined by a combination of a lot of different things. Uh, Cardiac output affects it, peripheral vascular resistance, blood viscosity, and blood volume are all involved. So for instance, if your vasculature is stretched or the stretch on it, the pressure on it is decreased one way or the other, increased or decreased blood viscosity, or increased or decreased blood volume, that will cause a compensatory change in your blood pressure. Systems that regulate the blood pressure are central nervous system, your arterial baro and chemoreceptors, and your renin, angiotensin, aldosterone system. Those all regulate blood pressure either directly or indirectly by influencing blood volume. When you have your cardiac output changing, your blood pressure will adjust to try to maintain that. Any change in peripheral vascular resistance will change your blood pressure, and anything that impairs normal regulation, sort of like in your kidneys or wherever, or in your vasculature, can cause hypertension. So there's a concept map on the next slide that talks about this, but blood pressure regulation is very complex. So as I said, things that control your blood pressure are very complicated, and this concept map is pretty complicated. Many factors lead to hypertension, and not all are very well understood. So when, for instance, you have an increased cardiac output called for because you have a physical stress of exercise, or an emotional stress, your heart rate will increase to meet the increased oxygen needs in the tissues. The peripheral vascular disease or resistance affects blood pressure by opposing blood flow through the vessels. And so anything that increases peripheral vascular resistance will increase the blood pressure because more pressure is needed to get that blood through the vessels. Your ventricles have to generate more blood pressure to overcome that resting systemic vascular resistance. Increased arteriolar peripheral vascular resistance is the main mechanism elevating blood pressure in hypertension. CNS overstimulation can cause that vasoconstriction. The baroreceptors can become less sensitive due to prolonged increases in vascular pressure. So it's the same thing as like chronic CO2 retention, that very same mechanism. And they can fail to dilate the blood vessels. Increases in hormones like aldosterone can cause fluid and sodium restriction. Changes in renal function can result in fluid and electrolyte issues that affect blood volume. All kinds of things, I could go on and on, have to do with the pathophysiology of hypertension. So the risk factors for primary hypertension are pretty much the same cardiovascular risk factors that we've talked about before. Non-modifiable versus modifiable. Your age, your gender, ethnicity, family history, those things you can't do anything about. So you really have to work on the modifiable ones. Alcohol, smoking, diabetes, obesity, stress, serum lipids, cholesterol, excess dietary sodium, big problem here in the US. And then, lower socioeconomic status is in the modifiable category here. I'm not sure. I suppose it is modifiable because you're not born with it. It is changeable, but it certainly contributes as a risk factor for primary hypertension. So a little case study here. We have 54-year-old woman who visits a clinic complaining of morning headaches. The nurse collects data and finds that she's an office manager, which may or may not be a sedentary job. She smokes a pack of cigarettes a day, eats fast food for lunch at her desk, has two children who are adults, recently divorced, and has 2 to 3 alcoholic drinks every evening. She's been in good health and takes 2 aspirin tablets every morning for her headaches. Let's look at her history and decide what risk factors she has for hypertension. Her age may or may not be an issue. She's a little older. Smoking, certainly. Diet high in salt and fat because of the fast foods that she discloses that she eats at lunch. Consumption of 2 to 3 alcoholic drinks a day. Her job is possibly high stress, also possibly sedentary. She's also possibly stressed at home because she's recently divorced. Just because your children are adult children doesn't necessarily mean they don't stress you out anymore. In fact, sometimes they're more stressful as adults than they are when they're younger. So, it just depends on the situation. So, what is the most significant information that she told this nurse, and why is it significant? I think it's the morning headaches. Because if you're waking up with a headache every morning, chances are that's significantly elevated blood pressure. Just devil's advocate here, could also be sleep apnea, but she's not complaining about fatigue or anything else. So I'm going to go with blood pressure here. And I think that that's something that she should be evaluated for. So if indeed she's diagnosed with hypertension and asks the nurse how long she will need to have therapy, how should the nurse answer that question? Well, lifelong therapy is required because there is no cure for hypertension and complications need to be prevented. Remember, hypertension is the silent killer, and so people need to remain on their treatment plan for life. So as I mentioned, there are often no signs or symptoms other than elevated blood pressure readings, and most people don't just go in and have their blood pressure checked routinely. And so hypertension is often diagnosed when they're seeking care for other reasons. Uh, and my guess is the lady in the case study came in because she was having morning headaches, not because she thought she had high blood pressure. Some people do report symptoms. Sometimes you'll see a headache, bloody nose, but those could be symptoms of other things. Sometimes people will even report severe anxiety or dyspnea, but the thing is, it's almost impossible to correlate signs and symptoms with the degree of blood pressure elevation. And so you almost never know unless it's an incidental finding when you're seeking care for something else or in just for a routine checkup. Just exactly how high does your blood pressure have to be in order to be considered high? Well, there's been a lot of change in the thinking on this in recent years. Older research was done mostly on men and mostly on white men, actually. And there's been a lot of studies done on different genders, different races, all across the population. And then there's also been some look at end organ damage and other complications. And so the blood pressure recommendations have really changed, especially in the last 10 years, they've changed. So normal, they're looking at less than 120 systolic and 80 diastolic. 120 to 129 and less than 80 is considered elevated. 139 or 80 to 89 is stage 1 hypertension. Now, this is very different because you used to have all this pre-hypertension stuff and whatnot, but they are looking at stage 1 hypertension now at 130 over 139 systolic or 80 over 89 diastolic, and that is a big change for a lot of people. That puts a lot of people in a hypertensive category that never, ever thought they were before. So stage 2 hypertension then goes to 140 or higher systolic or 90 or higher diastolic, and that is what we used to think of more as hypertension. And then, of course, a hypertensive crisis is pretty clear, 180 systolic and higher than 120 diastolic. And boy, I tell you, any higher than 100 diastolic, and I'd be in there. But anyway, that's what the American Heart Association says. So this has been a little controversial because treating people for hypertension is not a benign adventure. There are side effects to some of these drugs, and so there needs to be a lot of thought put into how we treat and evaluate this. And of course, now we know that exercise, diet, and weight loss do make a big difference. And so those people with the 130 over 139, or excuse me, 130 to 139 over 89 to 90 may not necessarily be treated with drugs. They may be treated with lifestyle changes. And I think that's the most important change here, is to look at those people in that very first category and say, listen, you're going to move up to that next category unless you do some lifestyle change. And that, I think, is the beneficial part of this. One high blood pressure reading does not mean that a person is hypertensive. Diagnosis uses averaged blood pressures, at least 2 readings, usually more, and these are done on different dates. There are a lot of places in the community where a person can have their blood pressure taken. Many pharmacies will do it or have automated machines that will do it. You can go into most fire stations, and if the EMTs or paramedics are there, they will take your blood pressure. You can buy inexpensive cuffs at the drugstore or on Amazon that you can use at home. So it's good to have a number of readings in a number of different settings, at rest, activity, that sort of stuff, to be able to compare and see what the person's like over the course of a number of days. Then there are other tests that they do routinely, an ECG, blood sugar, H&H electrolytes, specifically potassium and calcium. They, of course, look at lipids. They look at a UA to see if the person is spilling protein, and also at creatinine. Some of these are done, of course, to check for target organ damage. Um, the UA, creatinine, potassium, and calcium could tell us about renal damage, and then sometimes they also want to know different things about the person before they start therapy as well. So the goal of treatment is, of course, reduction of high blood pressure long term and to control it. This decreases the risk of stroke, heart attack, vision loss, kidney disease, all end organ problems um, can hopefully be prevented if you can keep your blood pressure under control. This quote here I found when I was doing some research for this lecture at one time, and I just loved it. It's from a British medical journal in 1931. The greatest danger to man with high blood pressure is its discovery, because then some fool is going to try his hand and reduce it. And that is so true because, as I said before, controlling blood pressure, especially with medication, is not a benign process because these medications do have side effects. So, a lot of coordination and thought needs to go into the treatment of hypertension and a lot of cooperation with the patient and the family and a lot of education is also necessary. Stepped care is important in treating hypertension, especially those people who are in that category 1, who I said earlier probably don't need medication, just need some lifestyle modifications. So one of the first things, no matter what category you're in, is smoking cessation. Very difficult to do, but absolutely something that needs to be done if you're going to keep your blood pressure in check. Weight reduction, also important. In fact, there are people for whom losing some weight is all they need to do to keep their blood pressure under control. Sodium restriction is very important. In this country, we eat a lot of processed foods, and restaurants put a tremendous amount of sodium in food. A lot of people sit down at the dinner table and pick up the salt shaker before they even taste the food. So if you can teach people to keep that sodium less than 2,400 milligrams a day, and then have them look at a diet plan that there's a DASH, DASH diet plan that is really good. The American Heart Association has cookbooks and there's recipes, all kinds of good resources for that. Alcohol restriction. So they're not saying don't ever drink again. What they're saying is alcohol intake shouldn't exceed a serving of liquor, wine, or beer for women per day, or 2 servings per day for men. Exercise. Really important, not only for weight maintenance, but also increases those HDLs. It's good stress release. A lot of collateral circulation is developed through exercise. Just cannot even tell you the benefits that exercise will give you. 30 to 45 minutes most days of the week is recommended. And again, we're looking at aerobic exercise here. A low-fat diet for both weight loss and cholesterol control, and also stress control. Your blood pressure is elevated through your sympathetic nervous system. And so if you're always under a lot of stress, you're always going to have a high sympathetic tone, and that is just going to put you at risk for a higher blood pressure. So another reason exercise is good, any kind of meditation, yoga, whatever it is you need to do, change jobs, whatever, to get rid of that stress is important. So if all that doesn't work, then the second step would be medications. A lot of times they will start with a diuretic first and see how they do with that, and then move up to other kinds of antihypertensive medications such as beta blockers, calcium channel blockers, ACE inhibitors. It just depends on the person. Everything's individual. There's so many different kinds of drugs, and different drugs work for different people. So definitely not one size fits all. So following up on that stepwise care, treatment guidelines from the American Heart Association, American College of Cardiologists, and the CDC talk about stage 1 hypertension being treated with lifestyle modifications, and if needed, then they will start with a thiazide diuretic. Stage 2 can be treated with a combination of the thiazide and an ACE inhibitor, an angiotensin receptor blocker, or a calcium channel blocker. And then if the person fails to achieve those blood pressure goals with the lifestyle modification and the medications, then they can adjust the doses of meds, do a drug from a different class, and add that to the treatment. So sometimes you'll hear people talk about 1 drug, 2 drug, or 3 drug hypertension, and that's kind of what they're talking about here, using medications from different classes to treat hypertension that doesn't respond to just one specific medication on its own. So treating hypertension decreases the blood pressure, but it also puts people at risk for orthostatic hypotension. And that puts people at risk for falls. And so one of the things that you need to talk to people about, especially older adults whose vasculature is less compliant, is how to prevent falls from this. So one of the things, of course, would be to rise slowly from a lying to a sitting position. Do not hold your breath as you rise, but breathe and then sit there for a minute before standing. Stand slowly, hold on to a stable object, and then stand there for a minute before walking. Another thing to talk to them about would be making sure when they're sitting, they're holding on to a stable object. They're flexing and rotating their feet a little bit, getting that blood flowing first before attempting to stand. Make sure they have their feet planted firmly on the floor before they're standing. Very important. Don't just get up and go. Think about it before you get up. Prepare. Then when they walk, have them not turn their head or their body abruptly to precipitate dizziness. Really helpful if they can call for assistance before walking if this is a big problem for them. And make sure that people know to report any lightheadedness or sudden dizziness. Another thing that may or may not be a problem for people is getting up after meals, because if you recall, your parasympathetic nervous system shunts the blood to your GI system to help with digestion. Remember, parasympathetic, rest and digest. So you may not have as much blood available quickly when you stand up, and so if they could use the bathroom before meals and then try to just hang out for 30 to 60 minutes after meals until the blood distribution equilibrates, that might help too with some orthostatic issues. So there are a lot of different cultural considerations here. African Americans tend to have a higher incidence of hypertension than any other minority groups, and also higher than whites. They are 3 to 4 times more likely to develop renal failure from that hypertension. And the most likely cause here is increased renin activity. So they respond better to diuretics than beta blockers. So when providers are looking at drug therapy for African Americans, they might look at it a little bit differently than, say, they would another cultural group. For whatever reason, African Americans also have a higher rate of non-adherence, higher rate of complications, and higher mortality rates. I would prefer not to pigeonhole this into a race issue in terms of compliance. I would more likely want to talk about that in terms of social determinants of health. And we'll talk about that in just a little minutes. The complication and the mortality could have something to do with the non-adherence. It could also be a genetic thing as well. That's really difficult to sort out. Chinese Americans are more sensitive than people of European descent to the effects of beta blockers, both on heart rate and on blood pressure. And so they require only half as much. They're also more likely to suffer fatigue from the beta blockers. And so there might be a better way to treat them than with the beta blockers. People of European descent, um, the beta blockers work better for them for whatever reason. But for everybody, I don't care who you are, what gender you are, what color your skin is, the social determinants of health are so important here because if you do not have the money for good food, if you do not have the money for transportation to follow up, if you do not have insurance or money to pay for your medications, um, these things are vitally important to maintaining a healthy blood pressure, healthy weight, keeping your blood sugar under control, keeping your weight under control, and also the stress of some of these things of not having the money, of not having transportation, poor living conditions, whatever it is. So economic issues, access to healthcare, dietary practices, weight, all reasons for disparities in um, not only levels of hypertension, but also complications due to hypertension. Older adults are more susceptible to orthostatic changes, as we talked about before. If you recall, they don't handle fluid volume deficits as well. And so if they're given diuretics, you need to monitor fluid balance and electrolyte balance very carefully. Not that you wouldn't anyway with anybody, but especially in older adults. They have decreased hepatic and renal function, and that may cause a difference in drug metabolism. So they may be more sensitive to medication and may need greater monitoring for side effects, also may need a lower dosage. They also have a potential for more chronic illnesses and maybe using more medications. So there you have an increase in the potential for drug interactions. So there's just a lot of reasons why older adults need to be watched more carefully. In terms of assessment, of course, you're looking at blood pressure measurement, but there's a lot more to it than that. Looking at their risk factors and figuring out what their non-modifiable risk factors are, and then helping them decide what they can do with lifestyle change. Of course, assessment for other chronic diseases such as diabetes and kidney disease are important. And a big thing here is motivation and support systems, because basically they're going to be taking a drug for the rest of their life that is probably going to cause some side effects. And they don't feel bad. And so, what motivates you to do that? What kind of support do you have at home to exercise, to decrease the fat in your diet, to take the salt shaker off the table? A low sodium diet is is bland. It's not horrible, but it's bland. And if the rest of your family won't do the changing with you, or you're not the person who cooks in the family and you're asking the person who cooks in the family to make all these changes, it's so what is their motivation and what support do they have to make the changes that they need to make? So you really need to be motivated to make long-term changes in your lifestyle and to continue medication use. Having empathy for these people is very important, and understanding the challenges they face both personally and in their family setting. dietary challenges. There are cultural issues with depending on what sort of diet you eat. Reduction of sodium intake and weight loss, I mentioned. Antihypertensive medications can have very unpleasant side effects, impotence being one of the biggest ones for men. Some ACE inhibitors have that nasty cough. There's just all kinds of side effects. They can make you tired, just a lot of things. And so why do you want to take a medicine that makes you so miserable and you don't even feel bad in the first place? The thing about side effects is meds can be changed if the side effects are not tolerable. So if you try one and it makes you miserable, try another one. There's a jillion antihypertensives out there. So don't quit taking it, change to a different drug. Erectile dysfunction is a big issue, but they may not report it. They may just stop taking the meds. So you have to be proactive and ask about that and make sure that you're not just asking about the obvious side effects, but the ones that they probably aren't going to tell you about. Smoking cessation, tough, tough, tough thing to do. They need support for this and help with it. Stress reduction, that's a very personal thing, and again, support for that is really important. Weight reduction, if they can get to within 15% of their ideal body weight, that is really, really a good thing. And so all of these things that I have listed here are hard to do. And so they need support from their healthcare providers and from their family members. And their family members need support from their healthcare providers as well. So the complications of uncontrolled hypertension are really dependent on the severity and the duration of the increase in blood pressure, because that determines the extent of the vascular changes. And really that's what causes the end organ damage, is the vascular changes from the high pressure in those vessels. Hypertension can cause damage to arteries, and it makes them less elastic, and then this places an increased workload on the heart. This can cause myocardial infarction, ventricular hypertrophy, congestive heart failure. The end organ damage is more of a small vessel damage, and that can happen in the brain, can disrupt the circulation, and can lead to TIAs and stroke. Hypertension can also cause damage to the small vessels of the kidney, and that can lead to renal failure. Can cause damage to the small vessels in the arteries of the eye, causing little formation of clots or the occurrence of small hemorrhages, and that can lead to blurry vision or blindness. So lots of things, lots of different organ systems can be affected by hypertension. One thing to note here is that your blood pressure should be well controlled before the person has any kind of an invasive procedure, because if it's not, that just increases the risk for stroke, MI, or heart failure. It's a big deal when you're having any kind of an invasive surgery or procedure. Get that blood pressure under control. If you have somebody who's MPO for surgery, quite often they'll say that they can go ahead and take their antihypertensive before the surgery. And then if they don't take them during surgery, the anesthesiologist would probably monitor for that in the operating room. But very important, get that controlled during procedures because the risk of complications increases. So I'd just like to touch briefly on hypertensive emergencies. Malignant hypertension is extremely high blood pressure that develops rapidly and will cause some sort of organ damage if not taken control of. It is very difficult to control. It's a blood pressure above 180 over 120, and your diastolics can get as high as 140. It is a medical emergency. So a hypertensive crisis has to be reduced within an hour to prevent organ damage. So the rule of thumb here is if you want to reduce your blood pressure by 25% over the course of an hour, or bad things will happen. They want to do it gradually to prevent a decrease in renal, coronary, or brain blood flow. You don't want to just bring it down quickly and suck perfusion away from one of your vital organs. This is treated in the ICU, usually with nitroprusside, which is a vasodilator that's given via IV drip and is titrated to the person's blood pressure. So it's done. I mean, this is the kind of thing where you're doing blood pressures every 5 minutes. It's a real emergency, and this kind of a crisis can cause an MI, heart failure, a dissecting aneurysm. They can have seizures. It's a real big deal. So finally, and with another case study, this time we have an 80-year-old woman who is being seen in the provider office. She leads a sedentary lifestyle, lives alone in her home. She's got a bathroom down the hall from her bedroom, and her son lives in the same city and does visit her often. What a good son. She's got a wood floor with some throw rugs in the hall and a tile floor in the bathroom. She has an unsteady gait and she has nocturia. She's 40 pounds overweight, has a 10-year history of hypertension for which she takes hydrochlorothiazide and propranolol, which is a beta blocker, when she remembers to take them. Interesting. When she remembers to take them. So risk factors here, non-modifiable, of course, are her age, and she does have a history of hypertension. But things she can modify include her weight and her adherence to treatment. Why is she taking both hydrochlorothiazide and propranolol? So thiazide diuretics are the first line drugs. And so what I'm assuming is she took that and her BP didn't come down, and so they tried adding a beta blocker. As you recall, beta blockers are sympathetic nervous system antagonists and bring down both the heart rate and the blood pressure. If she's not taking meds because of side effects, which beta blockers have a lot of, then she could try another med. What teaching methods can help her to understand how to follow her treatment plan? Well, first you want to identify her reading level and her primary language. If you give her written information, it should be in large type, and she could maybe use written information about her medications or diet. Also including her family. If her son lives there and is around, he pretty much knows what's going on and is probably involved in her life, knows what she eats and what she does during any given week. And so enlisting their support in reinforcing taking of the pills. There's those little pill reminders that you can get. There's all kinds of cool stuff out there now. There's even apps on your phone, although she may not be the kind of person for a telephone app, but all kinds of things you can do to remind you to take your medication and to support you in diet and exercise. So safety is important here. She's 80 years old. She makes frequent trips to the bathroom related to diuretics, which might be another reason she might not want to take her medication. Vision problems, and a side effect of propranolol is weakness and fatigue. She also has throw rugs on her hard surfaces. So, gee, what can you do here? Well, you could, first of all, talk to her about when she's taking that diuretic, because hopefully she's taking it first thing in the morning, and that's not the reason that she's up in the middle of the night. Talk to her about how to make the diuretic more effective. Take it, put your feet up, get some good renal blood flow going, get off as much fluid as you can very first thing in the morning. Hopefully that will help. How about a bedside commode for the evening, a nightlight? Get rid of those rugs. If she wants rugs, maybe get a carpet. Get some grab bars in the bathroom or the hall, or incontinence protection if she needs it. Just lots of different things you can do. And again, enlisting the son for help. is a big part of getting this done, for paying for it and for putting in the necessary safety things. Also, if she could be enlisted to a rehab program for exercise, maybe at the senior center, maybe through her provider, through a community, through a program, through her church, a lot of different ways that she could get into a rehab program. If money's a problem, Meals on Wheels. Senior centers often have meals. Churches often have meals. Uh, Maybe have dinner with his son and his family. Just lots of different ways that you can involve the family and the community in weight loss, proper eating, and help for this woman to be able to exercise, lose weight, and control